Let's start our next session. Sorry for the delay. As I cannot see the Teams screen, so if anyone wants to join, please let them in.
Okay.
So, this is the first case, a very common case in our routine setup, um, very frequent. So this is a 30-year-old patient who presented to emergency department because of weakness and tiredness, progressive weakness and tiredness, and he has some uh, infection symptoms as well, like sore throat. The emergency department have done full blood count. The full blood count shows hemoglobin of 90, platelet count of 900, and white cell count of 9. So this is power 10, just a general overview of the slide. Is there any volunteer who can start commenting on the blood film? The blood film will go to the lab first.
It's definitely a thrombocytosis. Could be reactive.
So we'll move to power 50, the oil side. So,
Body cells.
yeah, so you can see high platelet count. Here is a whole jelly body here, and this one as well.
For infection, I thought there'd be more neutrophils.
And this cell,
The spherocyte.
he has many spherocytes in the blood film.
Hmm. An autoimmune.
So how would you report it from the lab side?
I'd certainly say marked thrombocytosis.
Mhm.
Numerous spherocytes. Target cells.
And you have seen whole jolly bodies as
The
well.
whole jolly base queries. Hyposplenism. But I am seeing enough, really, looking around.
Because hyposplenism is also one of the cause of um, thrombocytosis.
Hmm. Not too sure was a HS or not.
Yeah.
Could
So
be.
usually from the lab, uh, we get a report that marked thrombocytosis excludes secondary causes of thrombocytosis if still any concern discussed with clinical hematology.
Yeah, that's about right. Yeah.
So this is the standard report that we receive from the lab staff. Is there any clinical hematologist who want to comment on this blood film or to report it for the exam purpose? There is no clinical hematologist with us today.
Sorry, I just joined in. Sorry, I forgot. I couldn't find the link, so I just joined in. Can you just repeat me the context? I'll report it.
Okay. So this is a 30-year-old young man presented to emergency department with worsening fatigue and tiredness. He has some sore throat like symptoms as well.
Mhm.
And he has blood test done which shows hemoglobin of 90, platelet count of 900, and white cell count of 9. The
And
blood
what?
film is first reported by the BMS and or the lab hematologist, and re- he made a comment that the blood film shows marked thrombocytosis, excludes secondary causes. If any concern, contact clinical hematologist.
Hmm. Okay, so what I can see from the picture that you have on the slide, there are a couple of spherocytes. There is thrombocytosis. There is some target cells. If you can scroll around a bit, there are target cells definitely.
What's the retic count like?
Retic count is 60. It is
Yeah,
under 80.
yeah.
Okay, it's okay.
I'm just trying. So I do see some platelets here. There's a marked thrombocytosis, some anisocytosis.
What's the LFT like?
Is spherocytosis doesn't add up to the picture, to be very honest. There are lots of target cells. This looks like, at least from what I can understand, looks like a giant platelet somewhere. Yeah, there are giant platelets in there. There are giant platelets in there. And did we see it? Is the DCT and bilirubin, what are they like?
The DCT was negative, and bilirubin liver function test is normal.
So then this is thrombocytosis until proven otherwise. In the context of an infection or a viral. So what I would suggest is three things. First, I will say this is thrombocytosis. There are spherocytes in there, and in the context of the history of viral infection, I would say that first two hematonex, B12, folate, rule out infection. If thrombocytosis persists, there's no other lines dropping apart from anemia. I would say that this first off start with the basics, start with the infection screen and viral and hematonex and whatnot, and then if all of the context it doesn't clear out, and if the thrombocytosis persists with anemia, then we can look at hematology review. But at the moment, I wouldn't recommend any hematology review for that matter. But yes, the spherocytes do look does not fit the profile. But other than that, the it is just marked thrombocytosis in a patient with viral infection. Not something that I would be interested in.
Can can spherocytes appear with bleeding?
Yes, they can. They definitely can. But this patient, the history you're giving is of a viral infection, isn't it?
Yeah, so you need to make a
Proper
report
history.
in which you have to mention the findings and you will
Yeah.
give some suggestions to them what to do next.
So what I would suggest is number one. So I'll mention what I saw. So I saw spherocytes. I saw target cells. I saw a thrombocytosis. White blood cell count. The white blood cells look all right-ish. I think it looks like a. Yeah, they look all right-ish. Yeah. So so neutrophils do look fine. I would suggest Hematomorph. Look, screen for bleeding, viral infections. I would say look for causes of to rule out bleeding in viral infections. Send for Hematomorph, DCT, liver screen,
What do you do
and then
iron
see.
profile in this patient?
Yes, there are target cells definitely.
Because
Hematomorphs
and
include iron and B12 and folate,
because they would think that the doctor has mentioned hematinics, so let's do folic acid and B12.
including
Mhm.
I would usually I write hematic including iron, B12, folate, the full package.
Yeah. So the blood film contains thrombocytosis. There are multiple target cells. We have seen few whole jelly bodies initially as well, and I think this is another one here.
Yes, I can see it.
The the platelet has an isocytosis as well. No
But there's
abnormal
no
white
trauma
cell.
history, right? There's no trauma history. The patient came in with viral symptoms, isn't it?
Yes, no trauma.
No trauma history.
Yeah,
So yeah. So in the context of the story, usually you tend to never find out until someone explicitly asks the question: Is the patient had any splenectomy? So
yeah.
cool.
So, so then you say that the impression is thrombocytosis, which can be primary and secondary. But first, we should rule out secondary causes by sending these tests.
Yeah.
And you would certainly receive a call from the department that this patient has platelet count of 900. Should I give? Should we refer it to hematology because this can be a myeloproliferative neoplasm?
And I will, if I'm on the receiving end of it, I would say first rule out secondary, then we talk about it. This is secondary until proven otherwise. So reactionary
Yeah,
thrombocyte, with given the history, there's tons of things. If you add a context of a whole jolly body in it, then this it could be secondary due to ton of things. Now you have viral infection, you have probably bleeding, you probably also have of course, infection, inflammation, iron deficiency. You have a couple of things going on here which would add to the picture of thrombocytosis. And the other question, and which I should have mentioned earlier, is there any previous blood counts to compare? Because the idea behind primary thrombocytosis is persistence of thrombocytosis with a platelet count of more than 450 6 weeks apart. So if that is the case, by all means, we can think about it. But anemia, thrombocytosis is secondary until proven otherwise. So I will say do this if the thrombocytosis can take up to 6 weeks to resolve. So if the thrombocytosis persists despite correction of the above causes, with no splenectomy, no clear secondary, patient can be referred to hematology. But in the absence of secondary,
yeah. So I bring up this case because it's a very common case in our hospitals where when the platelet count is high, the lab or the treating team on hematology say, is this a platelet cancer? Or so if there is thrombocytosis, we should always recommend exclude secondary causes. In UK, iron deficiency anemia and acute phase response is the commonest cause of thrombocytosis in UK. If secondary causes are excluded, there is persistent thrombocytosis, then you can send JEP2 or MPN panel for this patient. to exclude clonal thrombocytosis. Do we need a
May I add one thing? If someone has primary thrombocytosis, so even if the JAK2 is negative, it still doesn't rule out ET simply because that they are around, I think 25%, I'm quoting from my memory, 25% of patients could be triple negative. So a bone marrow is still required for a final rule out, even if your suspicion is high. But if the MPN panel is positive, it rules out nearly 70 to 80% of ETs, but 90% of the PVs. Am I right, Khalid? Am I right, Ahmed?
Yeah, so you catch my question. My question was, do we need a bone marrow biopsy for that? But you have answered that. Because WHO says yes and BSH says no. BSH says you should do bone marrow biopsy only if the driver mutations are negative. In triple negative cases.
No worries, just thanks. Sorry, I became overzealous in class. Apologies.
No, it's okay. So in FRC part exam, they will ask you to report the blood film, mention the secondary causes of thrombocytosis, and do we need a bone marrow biopsy for this patient or not? Or they will give you the last question that this patient has been diagnosed with clonal thrombocytosis now. His platelet count is 1200 and he bled on that. But he is a young patient. What is the treatment now? Treatment options now? So they can give you an acquired von Willebrand syndrome as a presenting case. Complications of thrombocytosis are allowed, or they can ask you that this is a 30-year-old male with clonal thrombocytosis only, platelet count is 900, but his BMI is 35, he has hypertension and diabetes as well. Should we do cytoreduction or not? Right. So this is a second case. This is a 21-year-old male patient who presented to medical ASDAC because he has high-grade fevers. He has noticed some lumps in the neck. So this is the general overview, power 10 of the blood film. Okay. So this was the general overview. Do we have a volunteer to chip in?
Leukocytosis.
Yeah.
I'm quite
There is
big.
okay.
Seems to be a few monocytes about, I think.
Okay, I will make it to power 10, power 50, to make the things more clear.
Looks a bit thrombocytopenia, maybe.
Yes, platelet count is low. So how the lab hematologist or biomedical scientist would report this?
Well, I'd say marked thrombocytopenia.
Mm-hmm.
I need to see a bit more.
Okay.
The whites. He's come in with swollen neck glands, is he? Expect to see more lymphocytes or atypical monos.
Mhm. I should add some oil to that. So what do you think about the nature of the lymphocyte?
Smudged lymphocytes?
Smudge? The one at 12 o'clock can be a smudge, but what about the other one?
Oh, there's a smudge cell there.
Hmm. What about this cell? Make it more clear, please. Any thoughts about this one? Or this one? So obviously, the lab person will refer this to clinical hematologist, but what usually they write, how they report it, before referring to clinical hematologist.
What is the lymphocyte count?
Lymphocyte count is 13.
Right. Okay. Yeah, it looks a bit abnormal.
Yeah, so usually we receive this from the lab that there are atypical large lymphocyte in this patient. Looks like a lymphoma.
Yeah.
So refer urgently to clinical hematologist.
Yeah, they don't look atypical, so I'd rule out glandular fever. Or...
So I think this is the typical picture in front of you now. I should not move from this picture. And this is a common FRC path question, appeared twice in the morphology cases in the last 3 exams. So we have mentioned previously, look at the patient A and the symptoms. This may give you some help in the diagnosis. This is a young.
It looks as if it's quite reactive. It's molded around the red cells. And it's more atypical shape. There's no clefts. I can't see clefts there.
What is this phenomenon?
Yeah, if they mold around the red cells, they're more reactive.
This is called scalloping. This is the red cell scalloping by lymphocyte. There is no prominent nucleoli. They have a lot of they have a lot of cytoplasm. It is basophilic type. These are reactive lymphocytes. Patient is 19-year-old, and this is common in the young age. And then you mentioned this patient has low platelet count as well.
Yes, it's just
And
viral then, isn't it?
is a response to the viral infection.
Probably glandular fever.
Yeah, most likely. Infectious molecule.
Yeah, you need a monospot and an EBV test.
EBV, EBV serology, monospot test. We also do hepatitis and HIV serology testing in these patients as well, just to rule out other
Yeah.
disease, viral disease. So the candidates that will appear in FRC path exam, they must produce a slide like this from the lab, and because if it had not appeared in the last FRC path exam, it will for certain appear in the coming spring 2025 exam. Yeah. Now, the next case is the 70-year-old male presented to emergency department again with tiredness and fatigue. So this is power 10.
There's marked leukocytosis again.
His platelet count is also low.
Yeah. The blast cells there.
Let's go to 50 then. So do you think this is a block? Or this
Yeah, that's definitely a blast.
just to see it more bigger.
Need to see if there's any rod there. There's nucleoli there.
Yes, and
Probably some myeloblast. Could be an M1.
this is another. We'll go to power 50 to see more cells.
Not much granulation there.
There is mild granulation, and when we looked at this slide first, this is a last week slide. We thought that there is a bit granulation. They are myeloid, but we get a different result on flow.
Mm.
Okay. Two more. Make it high power. So this film was rightly picked up by the lab hematologist.
Yeah, straight into the consultant's office. This one.
Yes, and he thought that this is acute leukemia.
Mm.
So
The cell
we,
markers.
we agree with that. We thought that this is acute leukemia as well. We send the blood urgently for flow. This blast has two nucleoli.
Acute myeloid done.
Yes, and and the flow that we get showed CD2 positive, cytoplasmic CD3 positive, CD5 positive, CD19 negative, 20 negative, and TDT was positive as well. So, what do
What
you
was the
think?
count? What was the total count?
It was 13.
Okay.
This is another blast with prominent nucleoli. And this will go to power 50 again. Right. So I have told you the flow cytometry. What is the likely diagnosis? Looking for a few more cells.
Sorry, can you repeat the flow again?
Okay. Uh, yes. So the flow is CD2 positive, CD3 positive, CD5 positive, cytoplasmic CD3 is positive, CD19 negative, 20 negative, 10 negative, TDT is positive.
Thank you.
Okay.
See.
So 3 prominent blasts in front of you.
Mm.
So what is the likely diagnosis on flow cytometry?
It's suggestive of TALL.
Yeah. And how did you pick that it is a TALL just for the purpose of other people?
The B markers are negative and the CD3 is positive.
What are
Plus
the B markers?
CD19, CD20 are negative.
Okay, CD19 and 20 are B markers and they are negative, correct? What are the T cell markers?
CD3 and CD2, and I think TDT is positive as well.
Okay, all right. So CD2, CD3, CD5, they are T cell markers. Other T cell markers and other lymphomas, CD7 is also T cell marker. TDT is a maturation marker. If it is positive, it means you are dealing with immature cells. If it is negative, it means the cells have matured there and they have lost TDT. This is a T cell ALL. Do you think it has a good prognosis or bad prognosis as compared to BALL?
Poor prognosis.
TALLs have very poor prognosis, and we always struggle uh, with the treatment in such patients. Right. So, what are other poor risk factors in TALL? This can be another Sifat question from you.
Still patient age, performance status, comorbidities.
Yeah. So, age more than 65 is considered as a poor risk factor. If the white cell count is above 100 in TALL, it is a poor risk factor. Hypodiploidy is a poor risk factor. Complex karyotype is a poor risk factor in these patients. Right. None of the consultant in hematology wants TLL to come in their week of control. Okay. So this is another case is 80-year-old female with persistent anemia and thrombocytopenia. So they did a bone marrow biopsy for this patient, and you can see this is particulate, but the particles are empty. Right. So why would have they done a bone marrow biopsy for biocytopenia to exclude what? This is power 4. Anyone?
Sorry, what is the age of the patient, please, Amir?
The patient age is 80-year-old, and the
Okay.
patient had persistent anemia and thrombocytopenia. So the hematology department decided to do a bone marrow biopsy for this patient. And you are seeing the aspirate at power 4 at the moment.
It's hypocellular.
Yes. Okay, I will move to power 10 now.
I see many megakaryocytes there.
Yes, there are megakaryocytes. What is there anything you would like to comment about these megakaryocytes? So these are all megakaryocytes. This- So what do you think is the reason of polycythemia in this patient, depending upon this aspirate? This is one of the easiest aspirate to diagnose in the FRC path exam. In general, what do you think can be the cause of polycythemia in a 80-year-old lady?
Myelodysplasia.
Okay. So the answer is in this picture, if you know what are the features of that disease. This is megakaryocyte. So what are the features of megakaryocyte in MDS? They are unilobular. They have only one lobe here. This is the characteristics for myelodysplastic syndrome with 5q. You will confirm that on cytogenetics, that is obvious, but if you see aspirate or trifine that has unilobulated or hypolobulated uh, megakaryocyte, the patient has cytopenias, persistent cytopenias, then this is likely MDS with 5q. Let me focus another one.
Will that convert to AML then? Or
Sorry?
will that convert into AML in future?
And any MDS can convert to AML because this MDS in the patient can be therapy related or radiation related, or this one particularly we are discussing related to 5q mutation. 5q mutation usually has lower chances to convert to AML. We haven't seen up till now with a patient having 5q MDS and later on they convert to MDS. We haven't seen any yet in practice. And second feature of megakaryocytes in MDS is that they are small size. So small size unilobulated megakaryocyte in aspirate and trifine is a feature of MDS. Then small size megakaryocyte is also a feature of chronic myeloid leukemia as well, but they are not unilobulated. Unilobulation is a feature of myelodysplastic syndrome. So there are two conditions which has small megakaryocytes. One is CML, another is MDS, and MDS is the one which has unilobulated megakaryocyte or hypolobulated uh, megakaryocyte. Hopefully, you will not forget that. Okay. So this is a 40-year-old patient who presented to the medical Aztec because of constitutional symptoms, weight loss, lumps in the neck, and he has low white cell count and platelet count on the uh, full blood count. The blood film was non-conclusive. Uh, no lymph node can be biopsied in him, unfortunately. Because of cytopenias, the team decided to do a bone marrow biopsy for this patient. And you can see the trephine in front of you. This is power 4. So this patient has likely lymphoma because the LDH is very high. He has constitutional symptoms. So I will go to this trephine. Can you see any features in this trephine that can help you in diagnosis? Any clinical hematologists who have seen the trephine? So this red is a normal bone marrow stuff. The problem is in the bluish area. The bluish part represents you infiltration of the bone marrow. But the position of this infiltrate is characteristic that helps you in diagnosis. Anyone who knows what can be the diagnosis here? There is a lot of silence today. I don't know why.
From a BMS perspective, we don't usually look at trephines.
Yes, that's why I asked from the clinical hematologist directly, what do they think? The bone marrow can be seen easily from the power 4. So this patient has peritrabecular infiltration, the bluish part, the peritrabecular infiltration of lymphoid cells, and peritrabecular infiltration of lymphoid cell is a feature of follicular lymphoma. And this is one of the easiest trephine to diagnose in the FRC path exam. There are features of diseases that you should cramp for the exam purpose.
Are those populations normal in the trephines?
Yes. This patient has a bit more vacuolation. He is a 30-year-old patient. I said 30-year-old patient. His bone marrow should be 70%, 70% cellularity should be there, but he has a little bit more of vacuole. So cellularity is slightly decreased, but generally okay.
Okay.
So you can see this infiltration here. It's the peritrabecular. The center of the trifine is all red.
It'd be quite interesting for BMSs to have a look at these. Be quite interesting for the BMSs to have a look. Consultants just tend to keep these to themselves, you know. But I'd like to see more myself.
Sorry, there was a disruption of my connection. Can you please repeat?
Yeah, the BMSs, we'd like to say we don't usually look at these, but I'd like to be involved more. I'd like to see bone marrows more, to be honest.
But the problem is that it's very difficult to bring out the refine. Aspirate, we ask the BMS, they make a slide for us, but refine is very difficult to bring out from FMB. This slide is given to me by my friend.
Yeah, histology is given straight to the consultants. We don't see these in hematology.
This is another small infiltrate. Yeah, so this is another small infiltrate which is just next to the bone, and peritrabecular infiltration of the lymphoid cell is a feature of follicular lymphoma. If there is peritrabecular fibrosis, it is a feature of systemic mastocytosis. The myelofibrosis bone marrow is very typical. You will see all fibrotic bands in them. The DLBCL, you will see large lymphoid cells because it is a diffuse lymphoma, a large lymphoid cell population in the bone marrow. Similarly, in ALL trifine as well, especially BALL trifine, it's full of lymphoid infiltrates. We had seen previously anaplastic large cell lymphoma trifine, which contain horseshoe-shaped cell, the specific cells for anaplastic large cell lymphoma. We had seen previously Waldenstrom trifine, which shows nodular infiltration of lymph node. So there are certain features of diseases in the trifine, which if you remember, you will pick it up in the exam easily. So that was it for today. Is there any question you want to ask? There was a lot of silence today. I don't know why. Maybe I started early.
Just out of interest, you know, when you do this exam, are you actually sitting by a microscope or are you just showing photographs?
Unfortunately, you have to have your microscope in front of you. This is a 3-day exam. So the first day is morphology. You will have microscope in front of you.
So there's usually quite a few slides to look at then.
Yes, you have 10 slides for short cases, and then you have 3 set of slides for long cases.
Okay.
Okay. Right. So this was our 15th session, and if I have slide, I will show it for the next one as well. See you later. Have a good.
Okay, thanks so much, Amit. Cheers.
Welcome. Take care.
Thank you. Thank you.
Yeah.